I'm going to hit record, and it's my pleasure to welcome everyone to this month's Open Medicaid Adult Dental Benefit Learning Collaborative call. As I just mentioned, today's call is being recorded. We'll share the recording along with any resources that are shared over open communities and via email directly with all of you. We'll ask folks to keep their lines muted until they're ready to speak so that we can avoid any background noise. But of course, we encourage you to come off of mute at any and all times to be part of the conversation, and also to use the chat box to share any resources, pose any questions, or pose any answers to questions posed by others. So with that all said, I'm going to turn it over to Melissa Burrows with Families USA.
Thanks, Stacey. Hi, everyone. I'm so glad to be here with you all today. I was disappointed that I couldn't attend the national meeting in St. Louis, so I'm glad to see many of you in this space instead. Today's conversation, we are going to first talk about a really fantastic new resource from CareQuest that, for those of you that have been with us a long time in this group, we've been talking about for quite some time, and it's finally ready to go and ready for you to use. So that will be the first item on our agenda. And then we're going to get into a good discussion about benefit implementation and utilization and some successful things that have been happening in other states, as well as raising some specific questions that folks have brought up to us. So that's the overall set of things we're going to get into today. Do folks have anything they want to make sure we add to the agenda before we get started? Great. With that, I will turn it over to Stacey Auger. Oh, sorry, go ahead, Bonnie.
Yeah, I'm sorry. I couldn't decide to chat or click, but too long to write. Any updates on the public health emergency status?
Sure, yeah, I can start with that. So the assumption is that the public health emergency will be extended again for another 3 months. We would have had a 60-day notice within the past week or so if they were not going to extend it, and that did not come out. So the assumption is that they will extend it again for another 3 months. Anything else folks want to make sure we discuss today? All right, then I will turn it over to Stacey Auger to talk to us about the fabulous new tool that they have released that I think will be extremely useful to all of us on this call. Go ahead, Stacey.
Thanks, Melissa, and thanks for your kind words. And I know some of you were really thinking we were never going to close the loop on this. I know that. We have talked about this for a long time. And you have heard Stacey Chazen, myself, Melissa, others talk about this thing called the rubric. And I'm excited to say that we have a slightly different name for this now. Some of you have seen this. This has been going around out from CareQuest on Open all over the place. And I so appreciate everyone helping to spread the word about this. But I am thrilled to announce that we have a new tool. It's the Medicaid Adult Dental Coverage Checker. And what this is we think really cool, very interactive tool that allows you to see states' Medicaid adult dental benefits, their packages, on a continuum from no benefit right on up to extensive. It does literally show you a rainbow continuum, which we think is very visually appealing and also easy to understand kind of where things are. And the data that is in this tool right now, it's in the Tableau platform. It is, I can't stress this enough. So this is a snapshot in time. It is from 2020. And the data that's in that platform comes from a survey, which is called the rubric, that we did in partnership with MSDA and through state dental directors or their equivalents. So again, it's 2020 data. And our intent is that this is going to be a survey that we release on a very regular basis. And then that this tool, the information in the coverage checker, is updated also on a regular basis. So that over time, we will be able to see trends and shifts, and also just really like the landscape of coverage, both at the state and national level over time. The thing about having data up like this is that things change quickly. We know that. We also know that since it is from 2020, there have been a ton. You all know this. You've all been doing this work. You've all been in the thick of it. There's a ton of information that's not captured in there, what has happened over the last years. We know that. So we are working hard to get a new survey ready and out into the field as soon as we can so that we can have much more up-to-date data. So more to come on that. I don't want to spend too much time talking about this today because I really want you all to come to our webinar next week. We have 3 of our Learning Collaborative rock stars that are going to present on this. Stacy Cheeson, Chelsea Foss, and Tanya Dorf-Brunner are all going to be joining me to walk through the coverage checker, talk about how we developed it, why we developed it, and how you can use it. That webinar is happening next Thursday on the 25th. It's at 3 o'clock Eastern. I put at the very top of the chat the link to the coverage checker. When you go to the landing page, you'll actually see a link to the registration. So if you haven't already registered, please go ahead and do that. We really want this to be a tool that everybody can use and that especially advocates can take and use to advance their efforts to expand and improve their benefits. So we'll be spending some time talking about that on the call, but also we want to use next month's Learning Collaborative call to dig into this a bit more, hear from all of you about, what is helpful about this and what else we can do to, create as wraparound resources and supports for this new tool. So I'm going to stop there. And I would just say one last thing, sorry. As you dig around this tool and as you play around with this new tool, in advance of the webinar, after the webinar, please reach out to me if you have any ideas, questions, suggestions, things like that. We really, I can't stress enough how much we want this to be something that's really, really useful to folks. We've worked a long time on it and we want it to be great for all of you. So I'll stop there, but thank you, Melissa, appreciate it.
Thank you, Stacy. Any questions about the new tool or how you might want to use it? I know there's a lot more to come, but if folks have initial questions, we have plenty of time for that.
Hi, Stacy. Nancy from Hawaii. So the maximal amount of points you can get on the checker is 32, correct?
Yes,
and the states are ranked in the checker from highest level to lowest level. Is that correct as well?
That is correct. We try very hard. This is not meant to be a ranking, and I also can't stress this enough too. It's not meant to be a ranking or a scorecard in any way. It is really meant to be a tool for improvement and for states. It's a couple different audiences, right? For advocates to be able to help advance their cause, but for states to also identify and policymakers to identify where they are and how they might move things along to better the health of their Medicaid population. And Mike and Stacey, please jump in and share any additional thoughts of him.
Even though it's not meant to do that, inadvertently, it does do that because we, our state's near the lower end and we can see that very clearly, which is actually very helpful. A little bit of shame, that's good. So, thank you for doing that because otherwise we wouldn't really know where we are in the kind of, in the mix. Thank you.
Yeah. Thanks, Nancy.
And I think the impetus for doing this is first that when we had just a map with different colors of comprehensive and non-existent and interim in between, that it wasn't granular enough to really know where you fit into that spectrum. So yeah, so it is meant to have a gradation, but it's not meant to be shaming in any way. It's just this is where we are. These are the facts, and so we try to make it as much of the facts as possible. And I think that it gives you that sense for each state of what are the things that we're focused on. And the other difference is that we not only took just that if it was covered, the frequency was an important part of the context for the scoring. So I think that because it's as important that it is covered frequently enough to make sure that it helps to support oral health and people's capacity going forward. But it will be a living document, and it will be hopefully a trend line, and it'll be easy to see where you could fit and what you could do in your state to bring things up.
I'm a great believer that sometimes a little bit of shame is a great motivator.
I have a question. My name is Christian, and I work as the executive director for A Smile for Kids. We fund orthodontic treatment for kids in all 36 counties in Oregon because Oregon State Health Authority does not. So it's not a covered service in Oregon. I'm particularly interested, obviously, in orthodontics, and I don't see that on the list. I'm guessing, and I'm registering for the webinar for sure. I'm guessing that it's just a matter of adding it later down the road.
It's actually focused on adult programs, so they're less a component in most states.
Okay, that's important for me to know that.
Yeah.
I guess I didn't catch that to begin with.
Oh, yeah, sorry about that. So,
yeah, well, I guess the webinar we're on today is adult Medicare benefits. So yeah, I get it. Well, then can you just make one really fast for kids too?
Our average lead time is 7 years based on this project. So sure, we'll get right on it.
I won't hold my breath.
That's the charm.
So part of the timeline was to engage the organizations that were using the map so that we could all be in sync with that. We could look at this as a different way to look at things. So it takes that to bring everybody along and have meetings over and over. No, we're kidding.
Great. And I also popped in the chat that the webinar will be next week, and then the plans are on the next monthly call of this group. We'll have additional time for folks to ask any other questions they didn't get answered on that call, or if you can't attend the webinar, but we'll spend some time getting a little more granular in any way that this group wants to on the September call.
Great. Any last words on this before we pivot? All right. So next, we are going to get into a conversation about a really important component of implementing a improved adult dental benefit, which is measuring its impact and success. We have Gary Harbison from Missouri, who's going to talk about what they have done. And I know there's some follow-up questions that Data from Arizona has. So we're going to start with what Gary has to share with us, and then I'll ask anyone else from other states to chime in, but also give Zeta a moment to pose the questions that are on her mind. So Gary, go right ahead.
Is there a way for me to share some slides?
Stacy may be able to answer that for you.
Oh, I think I found it. Let's see if it works.
There you go.
You can see that. Now I have to get into the slide view. All right. So we'll see how this works. So I'm going to walk through a lot of material pretty quickly, although I'd like to hear my own voice for the next hour and a half. I'm not going to do that to you all. I wanted to put a little frame of reference on this because I've been thinking about data for a long time. And I think I've paraphrased Peter Drucker here. I think he said information is data endowed with relevance and purpose. I think I added the data is not information. I'm pretty sure somebody said that sometime, but I couldn't find that exact quote. Peter Drucker, I'm pretty sure, said the second part. And I just think that when you're talking about measurement, you need to keep those kinds of things in mind. And that's certainly something we've done. I hope to illustrate that for you a little bit as we walk through this. I'm just going to walk through some pieces, kind of our perspective on both. I should say I have a hard time thinking just purely about measurement. I think it fits in a larger context. So that's why you're getting all this other stuff, including some history. But the way we've always thought about data infrastructure in the state, about the availability of data, about selling change and then measuring success, and about the changing context, relevance of your information, and then future goals. I'll give you a bunch of example data. I don't want to spend a whole lot of time on that. It's pulled from various sources because I'm trying to illustrate some of the ways that we've used data to kind of get out some messages related to our success. Then I'll make a few comments about broader applicability, and if I can speak, and kind of future orientation stuff. So we determined very early on that the state should be the ones doing the data. Some oral health coalitions fulfill that role. We worked in a very determined fashion to get a state dental director up and running. The state went without a dental director for over 10 years. We wanted to get that position filled. We wanted them to get money. We wanted them to focus on data and really have them take the lead. And in fact, that is how it's worked for several years now. We do maintain a close working relationship with the state dental director and the Office of Dental Health. I think that's very important to do that. If you want to have data available to you, you've got to be getting along with people. And I mean, it's been very helpful, and I'll illustrate that. The other thing I would say is data is a little bit of a conundrum. It's different, as we all know, in every state. There's always strengths and there's always limitations. I personally think it's a mistake to let the excellent be the enemy of the good. Work with what you have, make the most of it. Of course, I'm saying that from a state that happens to have a lot of data. We're kind of been terrible historically about creating reports, though, you know, accessing the data and spitting something out. And we've been fortunate with oral health to have some success with that. So we were, you know, back when we were working on getting an adult dental benefit, we were in an extremely conservative context. And I know many of you have heard this story before, so I'm not going to go on and on about it. But I mean, there was really a Medicaid expansion war going on with the Republicans swearing to fall on their swords. There was a lot of kind of what I would call ineffective grassroots activity. I'm not opposed to grassroots. I think it's great if it works. It didn't. A great example, they flooded the Capitol with hundreds of community members demanding Medicaid expansion. The Republican Party left. They heard they were coming. They just left the Capitol building, went somewhere else. They completely ignored them. So that's the kind of context we were in, trying to do something that could easily be called Medicaid expansion. We avoided that term like it was the plague. And we thought, well, okay, how can we sell this? It's not going to be something that would sell to a bleeding heart liberal. It's going to have to be something else. So we focused on operational data that shows waste in the way the current system exists. And specifically, we honed in on ER data because it's great stuff for that. We simply asked the Office of Dental Health to produce summary using available data sources. And fortunately, they have data available. This is actually a kind of a revised version of what they produced for us. The original was one page, one side, and they've kind of expanded, but you can see they haven't updated it since 2016. I pointed that out to them the other day. They probably ought to continue to track on it. But basically, the story is awful lot of non-traumatic dental services, you know, people showing up with non-traumatic dental conditions in ERs. And I think the original numbers were, you know, it's still in here. In 2014, they used $16.8 million on dental ED visits. That's a lot of waste. And we got a very strong response from everybody across the board. No one brought up Medicaid expansion. They brought up, you know, this is a dumb way to be having this operating. And, you know, these are people who aren't getting, I mean, you all know this story, but these are people who are not getting dental care in the ER. So that played very well. It was one piece of paper. We didn't produce it. The state did. It was just factual. There was no advocacy about it. It was like, this is what's happening. And it was very effective. Because of that data and the response to it without controversy in the middle of a Medicaid expansion war, we were able to get adult dental services started in Medicaid in January 2016. It was actually a little bit longer than that because these stories always have interesting twists and turns that would make a great, you know, Mystery of the Week show, but it made it retroactive to January 2016. So I've just pulled some data from here and there. So by 2018, we had a 44% decrease in total ED visits compared to 2015. And so that's kind of one of the big pieces of data we wanted to pull out, because we sold this on the basis of, look, dental people are showing up in the emergency department and it's a waste of money. They're not getting what they need. And, you know, it's important to note, it's really not fewer Medicaid participants. It's a rate, you know, the rate per 100,000, 38% lower. So pretty startling data. And then I'm going to start showing you some of the other slides. You know, we started looking at utilization. Are people actually utilizing the service we put in place? Yeah, they are, at a pretty good clip. I was a little worried about the dollar amount on this, because I thought somebody would come back and go, whoa, we're spending a hell of a lot more money than we did in the ER. Nobody said that. They seem to be pretty pleased with it. We noted that most of those claims were going through FQHCs, not private practice. No big surprise there. And we produced a series of graphs. This is one of my favorites. ED visits per year. 2021 is only 3 months worth of data, but you can see if you go back to 13 and 14, there was a slight drop in 14. We don't know why, but then it started going back up, and we smacked that and went down and kept going down. So I always feel like it's rare when you do a policy change and you see the data showing this type of change clearly, and this shows up. This has shown up repeatedly. We've used this a lot. We've talked this up a lot. So it's a real, you know, a real important message about success of a policy change that decision makers did. But this is just another way. It's you know, this is a per 100,000 participants, just another way of graphing it. And we've done this because we like to be really busy with some of our graphs. Actually, most of these are things that the state dental director put out. 2020 isn't actually, it's got a placeholder on here. It's not actually on here. But again, that's a month by month trend line. You can see drop, keeps going on, it keeps going down. And then guess what happened right after we got adult dental benefits in place? People started talking about opioids. So we started reporting on opioids. So that's the other thing. When people go to the ED, they're given a script for antibiotics, a big pile of opioids. Well, that's not literal, but you know what I mean. And they're told to go get a dental visit. And so we've seen that we were able to help with this burgeoning issue, or that people became aware of, by putting data out like this. So it was kind of a little bit of a pivot to get you know, more relevant data. We also started thinking forward. We didn't just leave it with just that data. And so we started doing things like this, doing graphics with numbers of licensed dentists per county. You can see on this particular graph, there's a number of counties with no dentist at all. And that's something that you want to bring up, and that helped lead to something that I'll talk about briefly here in a minute. Even better yet, we did one with just the Mo Health Net or Medicaid dentist. You can see lots of counties with no dental providers for Mo Health Net at all. So access is a big issue. We do have FQHCs all over the state. Many of them have, you know, outreach clinics and that sort of thing. But they're counted in this too. So and all the FQHCs in Missouri do dental. So this tells another story pretty quickly and pretty easily to kind of set the stage for, looking at the future. So I just wanted to note that, these reports get used really in a variety of contexts, including the state oral health plan. We have a thing called the Oral Health Caucus in the legislature. They have seen all this material and talked about it. And we've used it for other awareness building efforts as well. And I'd say kind of the uses of that material sort of unlimited. So looking forward, we've had another big Medicaid win that I don't know that many people know about, but partially because we got people to pay attention to data and we kept talking about rates and access to care. We've been able to get the rates to be up to 60% of UCR for Medicaid. That's huge. That was done separate from any rate increases for other Medicaid dental providers. It's really effective July 1 of this year, but we're waiting for the state plan amendment to be approved by CMS. We know from experience in other states that you can attract new dental providers with rates like this, people that have not done Medicaid previously. So we're thinking about how to do that. We know we need to do a lot to support dental practices so they can get successful. We also know from experience in other states that if it doesn't go well, in other words, if new providers sign up for Medicaid and they have trouble signing up, they have trouble getting credentialed with the managed care plans, they have problems with the billing process and rejected billings, and they don't understand it because it is a new ball game for someone who hasn't played in Medicaid before, that we'll start having providers drop out, and we don't want to have that. So we're trying to garner funds to have what we're calling a Medicaid oral health facilitator. We want to do a targeted media campaign, and we want trainings tailored specifically to new providers. There's a lot of other pieces to that, but that's the basic idea. So we also have that question now, what are we going to measure? And I think a couple of things we want to show is that there's actually increased access to care. So in this instance, the rates went up. We should see two things. We should see a lot more people actually getting dental care under Medicaid than they were in the past. And we should see new providers signing up and in new areas and staying in for the long haul. So that's just some of our thinking about going forward. We know we have to produce additional data because this has been a success, and the people who made those decisions and have invested in this, including the governor and the legislature and the Missouri Department of Social Services, they're going to want to know about the impact with that. So it'll be all hands on deck as we go forward. So that's it in a quick nutshell. I don't know if there's questions, or even if I entirely addressed what you all wanted me to cover.
That's great. Thanks, Gary. I see there's a few questions that have come up in the chat for clarity. So just scroll back up for a second, see what I missed. Let's see. So one is, how many FQHCs in Missouri have dental services?
All of them do, and I don't remember the numbers of FQHCs, but they're all over the state. They do have dental clinics, not just at one site typically. So the smaller rural ones, maybe only be doing one site, but typically there's multiple sites. As an aside, no surprise to you all, but all of the FQHCs are either telling us that they are understaffed now, or if they're not understaffed, that they're getting an awful lot of referrals from adjacent FQHC areas. So they might as well be understaffed because they can't handle it. And the private practitioners are saying the same kind of thing. That'll have a big impact on how we can move forward. The rates will be great. The new rates will be great for the FQHCs. We do not look to the FQHCs building enough additional capacity to meet the need. It's really the private practitioners we've always had our sights on.
And so kind of related to that, there's a question of whether the rate increases across the board or targeted at certain codes.
It is across the board for all the codes that they provide. We do have some additional issues with wanting to get codes added. You know, that's very important. We want to do it. Part of supporting new providers involves having a very good working relationship with the Mo Health Net division that manages the Medicaid, and what's called MMAC, which enrolls providers and does claims and audits. And so we are in a, you know, when you get a success, you have to think about what can you push on now and how do you push on it. So the word, someone has suggested on my board that we aggressively pursue new codes, and I balked a little bit at that word aggressive, because I think we could shoot ourselves if we get too rowdy with that. So, but I mean, detailed claims, I see that question in there. There is a lot of detail there. Quality, appropriateness of care, probably not so much, but the department does do audits. They are quick to recoup funds if they think things have been done inappropriately. There is a consultant dentist that works with social services that helps review claims. I don't think, you know, there's a great deal of problems with a lot of inappropriate care. Of course, that's another thing we have an eye on is, are we going to see a bunch of rape and pillage providers come into the state now because the rates are looking a lot better? We think we have some policy ways around that, but we're going to have to watch out for that. Yeah, so the rates went up across the board. We have done a little bit of analytics with that, comparing the old rates with the new rates. I'm hearing we're, taking when you do the math and it starts looking like even a bigger leap. So, it's over 100% increase. So it's pretty cool, but yeah, it is across the board. I'm not going to say they didn't do some squirrely things in there, or maybe they picked a particular code and didn't bump it as much or bumped it more even, but we haven't seen that. Thank you, Gail. Yeah, good work, Mary. That's great. Nancy, we do not have a written plan per se. There is planning going on, but those components I mentioned, we think there's several things that have to be done. Training specifically for potential new dental providers, support from this Medicaid oral health facilitator in doing the Medicaid enrollment. And we really want to get more at those office managers than the dentists themselves, although we need that too. But the people that really know the nuts and bolts of practice, support for the claims process, support for the whole credentialing process with the managed care plans. It's unfortunately quite complicated. If you start new, you've got to enroll to be a Medicaid provider and jump through all those hoops. And then you've got to get credentialed with the plans and deal with that whole thing. And, one thing we know with the managed care plans, they're not going to do a thing about this until they get a contract amendment. And, no big surprise. So there's going to be confusion and delays and lags and all that. But yeah, a person to kind of do some hand holding and troubleshooting and some training to really get out in front of this. We've already started messaging. This is a great victory. We know there's going to be a lot of bumps along the road. So we want providers to hear that and know that they should expect it's not going to be easy, but no written plan yet. I'd say the closest thing we're going to come to that is hopefully we get to the point where we can do a grant submission with one of our in-state foundations, and then we'll write out some more of these details in the form of at least a work plan. And then Kansas is also doing a great job. Oh, so someone's asking why did they increase the rates? So that is a part of the story that I didn't tell. We knew that there was a lot of federal money coming into the state, new federal money. And so, the context is changing. So we spun off a Medicaid work group from a policy committee that met weekly for months. And we specifically worked on what we wanted to ask for. We thought about who were we going to ask, and how were we going to ask, and what were we going to ask for. We did ask for new codes. To the best of our knowledge at this point, that part was ignored, but we also asked for the rate increase. They did not respond to us. The ask went to the department. It did not go to the legislature. It went to the department during session. Our state was scrambling to figure out how to spend all these federal dollars. And so we walked into that context. And I think the fastest, easiest thing they could do was just respond to the rate increase request. And they didn't tell us what they were doing in the meeting, but they sure did later. Next thing we knew, it landed in the budget. It went through the budget committee and it was passed and went to the governor. Nobody ever raised an issue with it that I heard anything about. Of course, it was mentioned openly in committee meetings. Nobody challenged it. I think that speaks partially to our years of work kind of building good relationships with the party in power, in particular in the legislature. And it went through, governor signed it, and here we are waiting for the state plan amendment to be approved. And if anybody knows how to make CMS move fast, let me know. We're not trying to pester them too much. So, are you saying that Mo sets the rate for all payers? No, they do not set the rate for all payers. Private insurance is a whole other gig, and Missouri has very few laws that have anything to say about private insurance and what they do. Literally the only example I know of that is several years ago, there was a law passed requiring insurance companies operating in Missouri to cover behavioral therapy for people with, on the autism spectrum. Other than that, really insurance companies can do as they please in this state. I imagine other states are similar. They're very powerful. They will shoot down anything that you bring up that they don't like in about 3 seconds. Sometimes they shoot it down before you bring it up. I don't know how they manage to be clairvoyant, but I've seen that go that way. So, Medicaid payers, yes, Bonnie, they do set the rates for the Medicaid payer. Well, okay, so if you're asking about the managed care plans, the general rule is the Medicaid managed care plans can pay whatever they want, but they cannot go below the fee-for-service rate. If that's what you're asking, that's where that goes. And there are some instances where they pay a little bit more. They're not terribly transparent about all of that, of course, as you might imagine. But yeah, that's kind of the general rule of thumb. I have talked to some of the dental benefits managers about this change. I don't see them having any issues with it. I think they'll pull up their rates to at least that amount.
Hey Gary, this is Nancy from Hawaii. I just want to say you've done an amazing job, and you really give us a lot of ideas about how to certainly look at data and measurement and implementation. I do want to call you though on your comments about advocates, because as this is an advocacy organization, we need to find some common ground where we can work, where providers and advocates can sort of work together collaboratively. Because if you didn't have those people flooding your capital, you probably wouldn't have legislators really sit up and take notice very quickly. They do respond to that. So I think there is a lot of discussion that needs to take place about how advocates and providers and policymakers can work together more collaboratively. It's certainly been an issue in our state, but I have to tell you, without a doubt, without our advocates, including myself, we'd be sitting back where we were in 2009 with emergency benefits only, no question.
I think,
thank you.
Yeah, no, I appreciate those comments, and I'm not trying to slam grassroots advocacy in any way. I respect it, and I've even manned the barricades a few times in fairly militant ways. I think it's always a question of what works in the context, and in this context, and I'll be honest, much to my amazement, the party in power explicitly said, we're not listening to you all, to the people who are grassrootsy. However, there were many other venues in, and people know, I mean, it was very pointed around Medicaid expansion. They just really were not going to give on that. We finally had to go to a state vote to get Medicaid expansion to happen in the state. That battle went on for over 10 years, trying to get it to be legislated, including with a lot of champions who were responsive. But overall, unfortunately, I mean, I think it should operate that way. There should be a groundswell. You should be able to build that. We had a lot of really resistant lawmakers that just, unfortunately, we're not going to have that. So I mean, we do advocacy. I think in these times, it has to be peppered with an awful lot of diplomacy, because people are very quick to put you on the other side, and boy, it gets tough then. It really took like changing up lead organizations to get to the point where we could get. And by the way, our legislature is still trying to figure out a way to kill off Medicaid expansion. They are still, even though it's been passed, it's been adjudicated. I mean, they're still trying to do stuff to kill it off. They tried to figure out a way where they could say the legislature could automatically cut Medicaid expansion if they just didn't budget for it, or they had a reduction in available funds or something like that. I mean, it's kind of nonsense, but I mean, that unfortunately, that's not going to go away. I mean, hopefully they're not successful. It seems like the Supreme Court's on our side, so the Missouri Supreme Court. So I don't know what will happen with that. It's quite the ugly spectacle. But Nancy, I appreciate your comments. Absolutely.
Great. Well, thank you, Gary. This has been extremely helpful, and I do want to open up the conversation. I know we've had a couple of folks weigh in the chat, but just to hear from others about how they are measuring these, or planning to measure the success of the implementation of Medicaid adult dental benefits in their state. And I know, Zeta, you had some specific interest in this, so if you want to chime in with what you would most like to hear about, please feel free.
Hi, yes. So this is a question that has come up quite a bit. We right now only have an emergency benefit. It's capped at $1,000. One of the things that we've been talking about and looking at is removing that language that says you can use this in an emergency, and potentially just saying you have dental care at up to $1,000. And then, we could subsequently lift that cap, or maybe add in some language that would supplement the care for cases where there was, also an emergent need. Oh, I'm so sorry, Christian. I'm in Arizona. So we're looking at a couple of different ways to do this in a very politically harsh climate, but potentially with a friendly governor. Please, everybody, cross your fingers and, like, I don't know, put something under your bed or something for us. I don't know how that kind of voodoo works, but please do it for us. So we've been talking about, ways that we can kind of work with the budget allocation that we already in theory have, and make it more amenable to people's needs. But when we are looking at that, part of what comes to mind is we know that there are people who do have emergent dental needs who are being denied care at Medicaid enrolled providers who, maybe do need an extraction, but are being told, like, we don't contract with Medicaid anymore for this service. We don't contract for the emergency services. We don't provide that kind of care. And so it's really hard to gauge realistically who's receiving the emergency dental benefit. We know who's received it and who has gone through the right channels at access for it. We don't know necessarily the proportion of people who have received it but are paying out of pocket for that care because they had to, or who maybe were denied that service because we don't have access to that kind of record through our Medicaid agency. And so one of the things that we're really hoping to kind of substantiate is, like, when your states adopted a Medicaid adult dental benefit, did you see an increase in providers who were willing to contract with Medicaid? Did you see an overall decrease in the utilization of emergency dental services or emergency room services? And then one of the other things that we're really looking at is we do have FQHCs that are providing Medicaid dental care. They're very limited in their ability to do so at this point. But right now they're really one of the only sources that people have. And so has there been any effort to potentially prioritize care through those existing networks of FQHCs that we know have this set up already, or of tribal health facilities, for example, for these services, because we know they're able and willing to do the work, and we know that private dentists often aren't, so especially here in Arizona. So just any information that anyone can give, any metrics that you've used to look at how this has changed people's lives would be really, really, really helpful.
I'm going to unmute myself and just say, Zeta, I'm Deb Jacoby from Apple Tree Dental in Minnesota, and if you want to connect with me offline, I think an analysis of state data that we did was very helpful, because there was this thing that the safety net can't grow to take care of more people, so we need to incent the private dentists. And the analysis showed that over time we have what we call the critical access dental provider program. So it's kind of, it's not exactly the safety net because because of complicated things, but the people who were receiving the rates that Medicaid paid. And it turned out that even though the number of them was very small, they were providing 2/3 of all of the Medicaid dental services. So it really showed. And then Dr. Helgeson, who's a analysis lover, converted it to FTEs and even looked at the rate that private dentists participate, how many more would you need to get the increase you want versus how many more safety net providers would you get. And I think it really wasn't a hostile thing towards the private dentists, because we pointed out the fact that they, they're subsidizing care. That was the other element. And it showed how much the safety net subsidized the previous rates and how much the private dentists subsidized the previous rates. And interestingly, I think it came out to be the same amount of, about the percentage that, like, Target and corporations do to give back, kind of thing. So, I mean, it was just a little bit of a different spin on saying, at least acknowledge that you're asking them to subsidize every visit that they provide. And we did get a nice increase. So if you want to connect with me offline, I think I have a link to something that you could see for that.
Yes, Deb, that would be wonderful. Thank you.
Yeah, that's really good, Deb. And I don't think I have a whole lot to add to that, Zeta, but I mean, when we did talk with the state about this, there were, I mean, we threw every argument we could at them for this about under accessed and the safety net can't do it all and all of that. And we don't actually know which piece they listened to, or if they were just like, oh, we got something to spend money on. Because I mean, literally, they were scrambling to figure out how to expend all these federal dollars, and they didn't even get them all, dedicated. There's additional funds. Hopefully, that'll work when we start going back to them to talk about codes again. Although they might say, "Oh, not you again." One thing I was going to mention that we haven't done anything with data about this, but the Missouri Missions of Mercy. If you track the numbers of people showing up at those events, since adult dental's come back in place, it goes down every year. And can you draw a direct correlation? No, but when you get to the storytelling level, there's video out there online and interviews with people standing in line at the MoMAM in Springfield and like 2015, 2014, and it's like a third world country. And news people they do not find those kinds of stories anymore when they go talk to people in line. They find people that are in need and they still couldn't get care, but it's not people that lined up 2 days before and they've lived with dental pain for 20 years. And so I don't know if that's something you could do anything with, but I think I've always felt like that was an untapped data source for us.
That's a really great idea, and I'll definitely look into that. Gary, I'm curious from your perspective, one of the challenges that we've seen is that we have funded Medicaid expansion using a hospital assessment in our state, and the hospitals are not having it anymore. They're like, if you want to add anything, you got to find a way to pay for it. That's especially difficult in Arizona because we can't pass any kind of new revenue increase without a supermajority vote of the legislature. And so it's not as simple as, a 1 cent sales tax or something like that goes to fund, to fund something like this. We really do need legislative approval, and we need to identify a fund source. One of the things that I've been curious about is whether you've been able to see an increase in the number of Medicaid enrolled providers who are offering dental services in your state, if that's something that you've looked at. I know basically our entire state is a medical shortage area, a dental shortage area. In particular, parts of our state that are less wealthy, largely Black or Indigenous or people of color, like many people see. And it's tricky to try and ask for more things when we know that we don't have the workforce in place, and we know that we're going up against the hospitals who really aren't going to be willing to shell out any more money.
Yeah, that is a tough one in that context. We have looked at numbers of Medicaid dental providers. There has been a slight uptick over a very long period of time, but it's an acute challenge. And the pandemic, we've seen dental assistants leave and not come back. We've seen hygienists leave and not come back. We've seen dentists who were kind of on the retirement track say, I'm going to go ahead and do that. So we have all those issues. We do have 2 dental schools in the state that are, purposely trying to get people to work in the state. So they get exposed at UMKC to working in an FQHC setting. And I do think a lot of their graduates come out saying, that's a great place to work. I'd rather do that than running a practice on my own. The other AT Still, Missouri School of Dentistry and Oral Health, they have that all the third years work at Affinia, which is a FQHC in St. Louis, gigantic clinic. So they get a lot of exposure to that. I think that helps. There's a third dental school that's going to come online. Of course, a lot of people go to those schools and then they go to another state. So I don't have a quick, easy solution for that. That is a long slog. It's a tough thing, and we still don't have numbers on that kind of fallout from the pandemic. When all's said and done, where are we? We just know more anecdotally people are understaffed, and that makes a tough context to get providers to sign up for Medicaid, right? I mean, a private practice in West St. Louis County, he's got plenty of middle-class people coming in and they don't have enough staff to serve them, they're not going to sign up for Medicaid. We're going to be talking until we're blue in the face before they even try that. We're hoping some of the we have found rural legislators and I think rural practitioners, because they're much more aware of their community and what the community needs are and who lives there, and that they're more likely to listen to those types of argument and stretch a little bit. So we're hopeful that we'll be able to get some headway there, but not without a lot of work. So
it's almost like we need a federal mandate or something. It's almost like we could use a federal requirement here. I don't know. Maybe some folks on this call can band together on that.
Yeah, that's an idea. I wonder why no one's ever thought of that.
Definitely working on it, but it's a long road. We just have a couple minutes left, so I want to make sure we wrap up everything that there might be left to close out. I'm just looking through the chat to make sure. I'm seeing a question about whether anyone's using patient-reported outcome metrics. Any thoughts on that? All right, and then go ahead.
Yeah, I was going to say, so we have a special project funded through the Missouri Planning Council for Developmental Disabilities, focusing on teledentistry for people with intellectual and developmental disabilities. And as part of that project, and that's a pilot in one particular area, but as part of that project, we are collecting information directly from the people served. And so there's questions, and we don't really have data yet, but there's questions about did they accommodate you? Did they listen to you? Did they meet your needs? You know, just very globally, did you get what you needed, and were these people decent with you? Obviously, we're a little bit more sophisticated than that, but that's the gist of it. And we think for that population in particular, those are very important questions to be asking. So we're traipsing into that a little bit.
Anyone else have examples they want to share? All right. Well, that really brings us to the top of the hour. I know there are a couple of things that we didn't quite flesh out in this conversation today, but our next call will be on the 21st of September at 2 p.m. Eastern, where we can revive anything we didn't get to today. But in the meantime, we will share the resources from today's call, including the recording. We encourage you all to stay in touch between now and next month. If we can make any connections for you, we're happy to. And if you need anything, you know where to find us. So see you next month, and thanks for being here today.
Thanks, Melissa.